Good morning, everyone. Morning. I sounded like a teacher there. Good morning, children. All well? How are you? Feeling good? Fine? Just fine? Somebody feeling okay? Lovely to see you all, and welcome to Kasvun Tuki Jubilee Seminar. My name is Kim Mohtonen, and I'll be your host today. It's my great honor to be with you today. In today's seminar, we will be taking stock from the pioneering work that has been done by the Itla Children's Foundation for the last 10 years, together with its collaborators, in supporting and promoting the well-being of children, youngsters, and families alike. We are joined by the leading experts in the field of psychosocial research, intervention, and implementation. We will shed light on the most impactful methods, share the many success stories, and of course discuss what the future looks like. Today is all about coming face to face together, exchanging ideas, networking, and actually having some good fun as well. Today, we know that times are tough for everyone involved, so today is all about getting together and having some positive spirit and coming up with ideas for the future. Does it sound okay to you? As Finns, we always take a bit of time to warm up. By 11 o'clock, we'll be singing together. It takes a bit of time, Marty, you'll get used to it. Well, once it happens, it's an unforgettable experience. This morning's session, as you all know, it will be in English, but if you want to ask any questions from our expert speakers in Finnish, please do so, and I will translate them for you, for expert speakers. And then in the afternoon, we'll change language into our native Finnish. Obviously, most of us are Finnish, but luckily we are grateful to have a lot of experts from overseas, so already thank you very much for taking the time to come here to be with us here today. And also, big thank you to everyone who has been organizing and making today possible. Let's give a round of applause to everyone who's been working hard already, weeks on end. Right, so without further ado, shall we get the show on the road? Yep, fantastic. It's my honor to introduce our first speaker. She is the vice chairperson of the board of trustees at Itla, and she has been an instrumental part of Itla for a number of years. Please welcome on stage Maria Kaisa Aula.
Thank you. Just a minute. Ei sitten tullut mitään. Okay, now. Dear promoters of children's well-being and children's rights, members of academic community, public policymakers, leaders and managers of child, youth and family services, and our guests, professors from Norway and UK, Monica, Tine, and Martin. On behalf of the Itla Foundation, I have a great pleasure to welcome you to this 10th anniversary of Kasvun Tuki. We call it early interventions in English. And a special honor I have from the Itla because Itla and Kasvun Tuki have in a way grown in a good collaboration and interaction during the last, let's say, 10 years or even more. And we have Itla nowadays is very strongly supported by the Parliament of Finland, but in the early years this was much more based on the NGOs and different funds, and also very committed persons who had visions and ideas to work for very long-standing processes. Long-standing processes are not very popular today. Usually we expect something to happen in a 4 months or maybe a year, but this has lasted 10 years. So this is really something exceptional in Finland. And I want especially to thank here Petra Kovonen, Dr. Petra Kovonen, who is the key person in having this vision and commitment. And I think we should give applause to Petra in this stage. And Itla Foundation, you said that I've been in Itla for a number of years, and actually that number is 20. That's a big number. 1/3 of my life, actually. I came to Itla already when it was hosted by Central Union of Children's Child Welfare in Finland. And then it later was kind of given a new birth with the Parliament of Finland when the Republic of Finland had its 100 years anniversary. And nowadays I would say that Kasvun tuki, early interventions, is kind of the flagship for Itla too. It's our most popular, most visited, most wanted activity besides others. And it's kind of it's a very good example of Itla's work for good future for children and families in Finland, where Itla wants to build bridges between research, practice and decision making, and producing data for professionals and decision makers, supporting services development and also the management of services. As I said to Petra that I was thinking of this morning that what is my role in this this Kasvun tuki or Itla, and I thought a kind of a quote word struck me. I thought I was a grey eminence. Perhaps it makes sense, even though I'm not grey, but I've been in background of this work for a long time, and therefore I thought that I could tell you a few words about the backgrounds, that where did we come to this place in these opening words. And probably many of you find your institutions and actors and networks from from this tree of Kasvun tuki, early interventions, and also the tree of growth of Itla. I think in the early, like 10 or 15 years ago, in Finland, we had a growing interest and growing knowledge and growing demand for the working for the human rights of the child, including equality of services. How do we work with the best interests of the child? How do we work with the current problems like mental health, promoting mental health of children, and also positive parenting? And at the same time, I think Petra came from
From the Nordic Center.
some Nordic center where she had been had worked with the questions of this is so difficult, intervention and implementation work. But anyway, something to do the services and support more qualitatively better for children in a way that we reach those results that we wanted to reach and base our work on knowledge and even evidence in the last place. And there was the Lastensuojelun Keskusliitto, Child Welfare Union of Finland, and also Onni ja Helmi Karttusen säätiö, which is not perhaps so well known, but was very crucial in the beginning of Kasvun tuki and the work for the quality early interventions and knowledge of what has an impact and what hasn't. And these child-friendly NGOs and committed persons were able to grow the tree further to so that the Ministry of Social and Health Affairs and LAPE, lapsi- ja perhepalveluiden muutosohjelma, Child and Youth Services Reform Program in Finland, took the Kasvun tuki early interventions as its one of its key issues to promote. And also we have this Nordic cooperation in the background. And then further, Kasvun Tuki has had really good research and development partnerships, like University of Turku with Voima, Perheille, Mieli, NGO with Lapsille puheeksi, Let's Talk About Children, Duodecim, that has brought the knowledge from the health, how do we evaluate the health services and comparing the work done in health sector and social work. And then University of Helsinki, which has launched the master's program using this knowledge and approaches in its studies. And then also, I think Itla was a kind of a pioneer in talking about ability to have an impact or evidence-based. If you think now today, everybody is talking about and the ability to have an impact and evidence-based, and our government program is full of ability to have an impact words, so that one has a feeling that it's already a bit inflated, that everything is having an impact. So, but Itla was the first one to bring these issues on the agenda, and for that reason, I think in the family, youth, and children's services, we are kind of far further. We are much better working on this field than in some other the fields of our services. So, no. So, I'm sorry. So, when we think about that, what do we celebrate here when we are celebrating the 10 years of Kasvun Tuki, working for the well-being, equality and good futures of children, young people and families? We celebrate exceptional continuity from project to project and also across governments. So if we think this as a relay, like a sports relay running for 100 meters, so Petra has been able to give the baton to the next projects and have this the continuity. And we are celebrating the committed visionary persons and decision making in Finland. We are celebrating networks and collaboration. There are a lot of activities, institutions, civil servants having to do, helping this. We are celebrating Nordic cooperation and inspiration among the Nordic countries, and we are also celebrating very systematic and persistent academic work, which has to, as I said, continue more than 1 year or 4 months. And I'm looking forward a very positive future for Kasvun Tuki and early interventions, because there is in the field of child, youth and family sector, there is increasing demand for impactfulness and evidence-based work, even on the social work sector. And from the politicians and decision makers side, I see the request for value for money, that if you put this money to this work, what is the impact? Or is this really useful? Or is this money wasted? And so I think these are good arguments that can resist these demands or provide the questions for this demand. And I see very positive also that we have the well-being counties as partners for the work with the Kasvun Tuki and early interventions. I'm myself a chair of the board of well-being county of Middle Finland, and I already noticed in the work done in the Middle Finland that these interventions and methods and implementation work, it is already not a whole mainstream, but going forward step by step. And for example, the Middle Finland county is, we have almost 300,000 persons living there. The budget is 1.3 billion, and we have 12,000 persons working. So these are very big entities, and this is something new in Finland, that we have institutions that can implement and can take the baton. And so, in order to work further for better lives and futures for children, young people and families, we need impactful mental health services. In my words, it's suitable service with correct timing. And we also need supportive communities to grow. It's not only methods or interventions, it's a question of all of us, the community around children in school, family, or early education settings. And we need evidence or knowledge-based interventions that are chosen, implemented, and adapted with good judgment. And I think today we are going to learn a lot about these processes. How do we provide better lives for children in family, school, and early education settings, together with Itla, well-being counties, municipalities, NGOs, academia, private actors, and with the support, long-standing support of Parliament and governments. So with these words, I wish you all very welcome to this event, and let's celebrate.
Thank you, Maria Kaisa Aula, and thank you for clarifying the exact number that you've been a strong instrumental part of Itla. It's always good for journalists to be specific. Some people. Right, our next speaker has also worked with Itla for a number of years, and it's around 10 years, if I'm not mistaken. Monica can verify that. If I get this wrong, I'm just going to get me going and go home. Professor Monica Martinussen from the UiT, Arctic University of Norway, Tromsø, is a long-term collaborator of Itla, and she will be sharing her thoughts on the close relationship between the portal Ungsinn and its Finnish counterpart Kasvun tuki, early interventions, and what kind of results this collaboration has generated over the years. Please join me in welcoming Professor Monica Martinussen on stage.
Thanks for inviting me. I love a birthday party, and I just came from one because my department celebrated 30th birthday on Friday. So this is indeed a good week. This is my grandson, by the way, on the beach in Lofoten. And we already heard a little bit what this is all about, why we're doing this. It's the whole point of having adults is to take care of the children and the grandchildren. And many of the things we do have that aim, even though it gets sometimes lost in between the RCTs and the research and administration and everything. But that's what it's all about. So, and also an anniversary is an opportunity to reflect a little bit, go back and see what we're doing in a little bit longer lines. And indeed, 10 years ago it started. We were guests in Vierumäki, and it was this time of the year, I think, and we had a great discussion, also a great dinner, and I enjoyed myself very much. And now many of the people you can see on the picture are here today, so you can look, this is a pre-test, post-test design. Do they look the same? I think they do. So in my presentation, I will talk a little bit why we are this evidence-based practice, why is it important? And then I'll talk a little bit about Ungsinn, which translates to young mind in English. And also another database called Psyktestbarn. It's about tests and measures. And then I'll talk a little bit about collaboration with Kasvun tuki over the years, some of the things we've done together, and also some plans for the future, because I think this is not something we are over and done with and then we can relax and retire. I think this work needs to continue, not just with the people who have been doing this for a long time, but also with new people coming on board. This is also from Lofoten. Why are we talking about this evidence-based practice? Well, this model came originally from medicine, but it's been adapted to psychology, social work, preventive research, anything. And it sort of means that we should take into account research, clinical expertise, and also the patient's desires, values, etc. Now, this model, the way it's pictured, is, I think, a little bit simplified because the circles are equally large, and I'm not sure that that should be the case. It doesn't really explain what type of research evidence is important. Is any type of research important? Well, I would argue that the evidence that supports the assumption that the intervention works as it should do is more important than other types of research in this context. And also, the professional working, deciding what kind of treatment or intervention should this child or family receive, needs to be well informed about what exists and also should be able to make some decisions. Is the evidence we have sufficient? Is it relevant to this specific child, family? A lot of the interventions and measures are adopted from other countries. Much of the research is conducted in other contexts. Is it necessarily applied? Can it be applied to a Nordic context? So the person working in the services need to make these judgments, and we need to support them with providing information that's easily accessible, for instance, through Kasvun, tuki, and Ungsinn. And there is a big difference between the medical field and when you have a new type of medicine or vaccine that you want to implement. There are really strict protocols that needs to be in place before a vaccine is made available to the market. There are different types of phases, simpler testing on animals, phase 1, smaller scale, and then an RCT, where the effects are checked and also side effects are looked at. The same is not the case for psychosocial interventions. People can make up their own interventions. Sometimes governments import interventions from other countries where there is absolutely no evidence that this will work, but it's still implemented. So I think children deserve a little bit better, and their families too, that we should not skip this important phase of actually accumulating evidence. And then with evidence, I mean in this case, research that supports the idea that this will actually work as it should. So in Norway, we have a lot of municipalities, 380 something, and many of them, only a couple of thousand people live there. So it's really hard for them to have access to all the interventions that they need. So sometimes when choosing what to use, the decision is, should I make something up? We have a problem with many young mothers. Many are depressed. What can we do? That is a big risk factor for the children. Should we make up something? Or should we borrow something from a different municipality where they develop something and they are really happy about it? Maybe that's the solution. Or should I pick something that is evidence-based? It's always many times more hassle in connection with that. It takes longer time to implement. There are requirements, there may be costs, but the likelihood that it will actually work if there is solid evidence is, of course, higher. Sometimes people say the intervention has been evaluated, but many times it's unclear what they actually mean. because there are many different types of research that we can do. We can do user satisfaction studies, we could do implementation studies, cost-benefit studies, and more. But more importantly, we need to do effect or effectiveness studies that actually will show and answer the question, will the intervention work if implemented in our context? It doesn't mean that the other types of studies are not important. Of course they are. But at some point in an intervention's life, those effect questions need to be answered. Now I will tell you a little bit about Ungsinn. We've been lucky that our center has received funding from the Norwegian Health Directorate for a long time. So as part of our annual budget, it comes a shopping list from the Health Directorate, and where they state what they want us to focus on. And Ungsinn has always been mentioned. And we started out in 2006 with starting up the project. It was launched as a database in 2009. We have improved the web design. We turned it into a journal. And we have, over time, developed the criteria that the researchers use for assessing interventions. And now we are doing some more changes where we have the scientific journal part as one part, and then more easily accessible information available in a web page. So it's been a long journey where we have been able to recruit researchers all over Norway who help out with making the assessments and evaluating different interventions. And to summarize the findings, we have different levels of evidence where you can think of this as a ladder where you climb the different stairs, and as you do more research and you add on more implementation, you strengthen the evidence, and at the very top, at level 4 and 5, you have strong, satisfying or strong evidence that the intervention will actually work if used in Norway. At level 3, there is some evidence, but not as strong. And then the first 2 levels means that you need a description of the intervention, and also it needs to be theory-based. That needs to be something that explains the mechanisms, why you're doing what you're doing, how will this lead to improved mental health or reduced anxiety or whatever. And also at some point we had to add on a level 0, because it turned out that not all interventions work. Some interventions, after doing rigorous testing, turn out with no findings, and sometimes it can actually be that they have harmful effects. So we needed to add a level 0, and I think we have 1 or 2 interventions that are classified on that level. Here are 2 examples. PMTO, probably something that some of you have heard of. The other one is SIBS. So this is the summary, the front page. So if you don't have time to read the whole article, you can get the level of evidence that will tell you how much documentation do we have that this intervention will work. The lower levels level 1 and 2 doesn't mean that it doesn't work, it just hasn't been tested yet. We have around 80 reviews by now in Ungsinn of 43 interventions. And as you can see, when we sort them according to evidence level, not many are on the 2 top levels. The majority is where there is a theory behind the mechanisms, so it means that there has been no testing whatsoever. Here is also an overview of site visits. So it's been going up steadily, a little dip during the pandemic, but it's been a lot of hard work to get people to to know about Ungsinn and to actually use it when they're choosing interventions locally. In addition to Ungsinn, we have another resource. It's called Barn, and it does much of the same as it's done in Ungsinn, but for measures. And there are many different guidelines on how to assess tests. Most of them summarize findings on reliability, validity, and norms. So what we're doing in Barn is that we start with measures, tests, assessment instruments, diagnostic systems that are in use in Norway. And then, sort of the same way as we do in Ungsinn, we have two authors who go through all the documentation and who write an article and classify. We don't end up with a classification, but we end up with an assessment of how well is this test documented in the Norwegian language. So this is the front page. Unfortunately, both those resources are in Norwegian, but at least there is some information in English, and also the abstracts are in English. So that is at least the starting point. Here is an overview of the tests that are mostly used, or where people go in and read the articles. And I guess some of the abbreviations are known to you from earlier days. So those are the two resources that we have in Norway that will help practitioners choose interventions and also easily get an overview of what is done, how well is this documented. And of course, we want the politicians, the decision makers, the government to use this as well when they import interventions and also when they decide what to use and implement. And I guess for many interventions and areas, there aren't that much research, but at least then there needs to be a plan on how this can be evaluated and assessed. So now a little bit about the Nordic collaboration. This is from, I think, Petra, this is 10 years ago, when we were working on family center, family houses in Stockholm. And also, we have been meeting there, not just Norway and Finland, but also Sweden and Denmark, almost every year, I think. And we discuss how we're doing things. We have developed a little bit differently, but there are many of the same issues and problems. So here is one from Stockholm, Copenhagen again. And as you can see, Petra is in all the pictures, almost. Here from Helsinki. And I also will talk a little bit about a big project that we did together, Kasvun, Tuki, and Ungsinn. And it was a project that was funded by the Nordic Council of Ministers, where they wanted us to look at interventions for small children, babies and their mothers. And usually it takes a long time for us to write an Ungsinn article. It may take a year. But often the politicians and decision makers, they don't have a year. And if they want to do many reviews, how can this be done quickly? So can we do like 80 reviews in 1 year instead of 1 review in 1 year? And we can if we simplify and have enough people. And this is because it happened during the pandemic. It had to be online, and I apologize for the picture. Not all look their best in this Zoom picture, but it tells you a little bit how we work together. And we were 12 people from Ungsinn and Kasvun Tuki who decided on, can we simplify the systems that we are currently using to do a lot of interventions and a lot of tests in a very short time, and still be transparent about the way we're doing it. And so this was a type of very rapid review, and we decided that we want to try to rate the interventions in terms of quality and level of evidence, and it should be based on, of course, the number of studies that have been conducted, the relevance to the Nordic society, and of course the findings. And we used both the Ungsinn and the Kasvun tuki criteria, and also some methodological books that we share knowledge of, and decided, can we classify the interventions in 4 levels? No evidence, some level, good, and high. And of course, the evidence-based should be the green levels. For tests, we made a similar system, no or low level of quality, some level of quality, and very good quality. And the way we worked is that we did a systematic literature search, and we assigned tests and interventions to different authors depending on their both interests and also their experience. And we did a very quick literature search. They went through it, and they write very short reviews. And the editors, we went back and forth with the authors until everyone was happy, and then the final version was put into a big report. And just to give you a little bit some of the results, because I think it describes our field a little bit, that the evidence we have isn't overwhelming, and maybe even more so for the smallest children, that there is actually a lot of stuff missing. What we did find based on all the Nordic countries was 33 tests used for this target group and 63 interventions. And that was from all the countries. And to summarize, for the interventions, the majority ended up on the lowest level, no evidence, 29 with a little bit, and as you can see, only 14% together who had the highest, where we can call it evidence-based. So, here's a little bit more about the results. Many of the tests were, some were aimed more at the adults, the parents, and some of the interventions were really made for older children and not so good, probably not so good for the youngest ones. When it came to the tests, the measures, there was a little bit more on level 2, but still level 3 and 4, very few tests were actually checked out in a Nordic context in terms of the reliability. Do they measure what they think they're measuring for this target group? Are there any norms that can be used, etc.? And many of the best tests were actually adult screening tests. And not so many tests were developed originally for the target group and given a proper assessment. So there's still a lot of work to do. And of course, the practitioners and the clinicians working in the field, they have to do something while they're waiting for the researchers to do the tests. And then maybe the lower levels of evidence can help, like having a description of the intervention, having a theoretical background, why do we think the mechanisms will work the way they're doing, and then having plans and starting up doing simpler types of testing. And I think implementing nationally interventions where there are no evidence and there is no plan for testing, I think that's almost irresponsible. Okay, the future. I think there is still a lot of stuff for us to do, both checking out the tests and measures that we are using, also the interventions. And I think our databases can offer decision support for leaders and others, so that we have to make it both as simple as possible, the summary findings. We have sometimes to do things quickly to meet the demands. And then this information can be available not only to researchers, but to practitioners and also those who make decisions what to implement locally. And in Norway, in the many municipalities, they have a strong independence and can choose for themselves what to use. So then it's important that they have the the necessary resources available to do that can support their decisions. And of course, deciding on what to use depends not only on the evidence, it depends on the money, availability. There are many other issues, but evidence should be a part on that equation. And then for our future collaboration, I think the sharing and learning part is important. I think there are many similarities between our Nordic countries in terms of culture and history, and I think we can learn a lot from working together. And also, we have small countries and not that many people. If we're doing studies, I think it's important that we can use the evidence and share knowledge between us. And I think inspiration is also an important part, and developing joint projects in the future. And I would like to congratulate you with your 10th anniversary, and this is the editorial board in Ungsinn. I know they would have loved to come as well, but here they are, and I know there will be a meeting in the fall in Helsinki as well, and I think that can be an opportunity to discuss further collaboration. Thank you.
Thank you, Monica. Would you like to stay with me for some questions?
Absolutely.
Now we've got plenty of time to take questions for Monica in Finnish or in English, either way you want. And obviously, people accessing our seminar through remote access, please send your questions in the chat box.
I can do Swedish, Danish,
Wow.
not Finnish. Yeah.
Introduce yourself in Danish.
Monica.
I understood every word. Probably I speak Danish too.
Yeah.
That's actually, I think, the first picture with Petra in it.
Yeah, exactly. Yeah.
Just, I was thinking as a journalist, not as an expert or someone who works in the field, and I was thinking about this. You mentioned about this Nordic collaboration. Our countries have a lot of similarities. We share the history. So when we reflect that and that collaboration of 10 years over, what kind of hopes, wishes you have for that collaboration that you could do together between Nordic countries?
I think we can utilize it even more when both doing studies and also compiling evidence across the borders. And I think we've done it in a couple of projects, but I think that's certainly an opportunity that we can use more. And also when you do studies, finding enough families or children with a certain problem at the same time is hard within one country. So maybe we should think a little bit more cross-country in terms of doing studies as well. But certainly sharing knowledge and learning from each other. And when we discuss things, there are many similarities in how the political system works, how things change over time, what kinds of things that are on the agenda, the cost. Do we get the money back from the investment? I mean, there are many similarities, I think, and so we can benefit from learning from each other, definitely. Yeah.
And on that political note that you just mentioned there, we know times are tumultuous, and as you mentioned, decision makers, they don't always think about societal things in the long run, more like in the few years, one election term. So part of the plan. It's all right, yeah. So I was just thinking that when you've been communicating to decision makers and politicians, let's get on the stage again. Have you noticed like certain kind of wisdom might be the wrong word, but kind of tactics or strategies? How can you communicate this the importance of this evidence-based work and the time and the money required to do that properly?
Yeah. Now that is a struggle, and you have to keep saying it in different ways and try to enter it in official documents for one thing. That's an important thing. So when there are hearings on policy documents, you should make sure that it's mentioned. And then, but you just have to keep going. And I think there's something about our field, children, families, bringing up children. Everyone thinks they know a little bit about that. You wouldn't have these arguments in cancer research or vaccines that we can sort of think about what will work and then it will work. No. So we need actually to have documentation. So you have to just trying to push that argument and explaining that these things take time and that we need long-term strategies. And also in Norway, some of the services for children and young people, they have 30% turnover in a year. So also the need for continued education training is also big. So we have to keep that in mind as well. Yeah.
And if you have any questions, just please raise your hands. Raise your hand, and we've got mics, a few mics going around. There on the back left, please. And there's a question coming up. Thank you, Monica.
Thank you for the presentation. My name is Nora. For it, we review.
Yeah.
Bonus sucks.
Yeah.
So we need the need for the reviews, but we also struggle with the quality of the evaluation.
Yeah.
So what would you say are the strengths and the weaknesses of the rapid reviews?
Yeah. Well, as you said, the quality, having a system that's both transparent, so other people can agree or disagree with the way you've done it, and also training the reviewers, having them on board in a certain system so they do it more or less in the same way. I think having highly qualified researchers do it and having them trained in the same system and having explicit criteria is probably the best way. But of course, there's always a danger that rapid reviews, you miss something, that maybe the literature search wasn't sufficient enough. But I think having a system like we were thinking when we did the one for the Nordic Council, we thought a little bit like a journal. So we have authors do it, we have reviews, and then the editor makes the final decision, and then we go back and forth until everyone is happy. So that is the quality assurance system. But of course, there's always the issue when you do so many in such a short time that it's not perfect. Yeah.
Thank you very much for your insight. Unfortunately, time's up, so thank you for insight and inspirational speech.
Thank you.
Monica Martinussen.
Oh, please don't fall off.
I'm not going to stand here now. If I'm going to get through the day without breaking my leg, I'll be happy. Right. Our next speaker will be joining us through remote access from Norway as well. Do we have Professor Tine Nordgreen online?
I hope so. Can you hear me?
Yes, we can. Lovely to have you with us. How is the weather in Norway?
It's okay. 10 degrees, a little bit cloudy, at least in Bergen, where I live.
Fantastic. We're really happy to have you with us. So without further ado, let's give a round of applause to Tine Nordgreen.
So thank you very much. And first of all, I want to say I'm very sorry that I'm not with you. My Finnair flight was cancelled yesterday, not only delayed, but cancelled. So that's why I meet you from Bergen. And then I also would like to congratulate you all. I already know Petra, and we had a meeting earlier this spring regarding interventions for children and adults and her group. And I want to congratulate you all for the big Jubilee seminar. So it's really nice to be able to talk to you, and I wish I could talk with you also in the breaks and during lunch and everything. But please take contact if there is anything we could discuss further after this presentation. And I think what we have in common is working for better lives and for a better future. I'm presenting the digital interventions, both in prevention, in treatment, in rehabilitation. And for children and adolescents, programs are coming in Australia. Both preventive and treatment programs have been developed for many, many years. And I think in the Nordic countries, we are getting there. So the Swedes are, I would say, in the forefront, and the rest of us are following after as good as we can. So both digital preventive programs and digital treatment programs has been developed for children and adolescents. And I think it will increase a lot during the next few years. So, and you must let me know if did I turn my slide? Yes, it looks okay. So what I've been working with for the last 15 years is guided internet-delivered treatments. So in this example, it's programs that are delivered in secondary care. And what we typically do is that we have an assessment of the patient. We assess their symptoms, their needs, and if we find internet-delivered treatment as a good alternative, then they enter these programs, and they typically consist of 5 to 10 modules. They include text, video, audio, and then we monitor symptoms. And the programs also provide weekly therapist support. So for preventive programs, they would often be self-guided or automated, but in the healthcare services, they are often followed by a weekly therapist support. And then the patient works with these programs for about 5 to 10 weeks, and then we meet again. It can be face-to-face or through a video consultation, and then we see if this was enough, if it was not enough, if people need something else, or if they are good. So these kind of internet-delivered treatments has been developed all over the world for the last 10 to 15 years. And in Norway, we started this in 2013. So the first picture here was a very small first group. And the second picture is, I think, from 2015. And then, and now, as of 2024, these programs are implemented in all the health regions in Norway. So in Norway, we have 4 health regions, but we have, like Monica said, more than 300 municipalities. So currently, this is quite well organized within the specialist mental health services, and the 4 health regions are active parts of that work. But we'll come back to discuss how this might also be done in the municipalities. So the field of internet-delivered interventions are about 20 years, at least from the pioneering countries. And what we often say in our abstracts, in the applications we write, or the presentation we keep, then we often argue that, first of all, the common mental health disorders are leading cause for the worldwide burden of disease. And I don't need to tell that to you. You're very much aware of this. And then we often continue by saying research findings from the 2 last decades supports the efficacy and the effectiveness of internet-delivered interventions for common mental disorders. And this is true. And then we continue, and this is maybe the more sketchy part, where we say internet-delivered interventions are a promising way to improve access to psychological therapies for common mental health disorders. So as Monica was talking about the evidence base, in this case, the evidence is good. And there's hundreds of trials demonstrating the efficacy and effectiveness of different internet-delivered interventions for adults with common mental disorders, but also lately for children and adolescents also with, for example, common mental disorder. But what we are struggling with is to see how this can affect our health services, how it can help us health services, and how it can reduce the burdens in the health services. So I will argue that we should not sell the bear skin before one has killed the bees. And I would love to know what this proverb is expressed in Finnish. But this is one way to say it. So we might have been underestimating how difficult it is to implement or scale up also internet-delivered interventions. And now from our experience, it seems like it takes the typical 12, 15, 17 years to implement also these interventions, as we know from other implementation research, which is quite common, both within the medical and the mental health fields. So what I would like to talk about is to give you some evidence, but not too much about that. But I will be mostly talking about how we can scale up and thereby make an impact of internet-delivered interventions. And just to remind you, this can be on the preventive side, on the treatment side, but also on the rehabilitation side. So I would very briefly go through this, the evidence base, but we have then 20 years of evidence for common mental disorders in adults. We find large effects for common mental health disorders. We see promising results for patients with psychosis, just as an example that it's not only for anxiety and depression and very kind of narrow problems these interventions can help, but they can also help with more complex and more severe mental health disorders. And then most researchers anyway agree that the guided interventions increases effect. But it's especially in the prevention field, we need to be aware that if we are able to offer good unguided programs, even if they have somewhat lower effects, they will be available for many more patients or inhabitants. So that is also worth mentioning. And then we in children and adolescents, and I'm still talking about internet delivered interventions. And here there is somewhat less evidence, but there's increasingly good evidence also for the field of children and adolescents. And here we see that these are more effective than passive controls. We see them just like the adult field, that they're as effective as active controls. So that meaning that they are as effective as other treatments or interventions. And also here we see that the guidance gives better effect than fully automated programs. This might be the adherence actually. So we have maybe a dose effect relationship. And as you see, these studies were mainly conducted on anxiety and depression and a combination of those. Then we also have the qualitative results from the child and adolescent fields, which are particularly relevant for you and this group. What the adolescents and children say is that the pamphlets are boring. I guess that there are still around at the hospitals, at the schools and other places, we can still find these pamphlets. What is ADHD or what is anxiety? But many of the adolescents would say that they can be quite boring. It also seems that the adolescents and children, they are concerned when it is bad user interface. So if they don't find it appealing, then they do not find the content or the information as credible as they would if it was more gamified, or if they had some interaction, or if they could connect more emotionally to the contents. So it seems like, and it makes sense, doesn't it? The social media has given them quite high expectations on how to present new knowledge, or at least knowledge. So they also expect from us, when we give them information about their health, about their mental health, about resilience maybe, that it should be a good user interface, and to have some gamification and interaction is appreciated. So these, I think, it's important lessons learned from from the field, also from children and adolescents. So just as an illustration, and because we are quite proud of this one, we'll see if this works. This is a result from, we have conducted, what we usually do when we develop new intervention is that we interview the target group. So this is targeting adolescents with ADHD between 13 and 16. And how we made this in animation is based on the interviews with a lot of adolescents to understand what's important for them in an ADHD psychosocial intervention. And then we develop something, and then we show it to them, and then they give us feedback, and then we continue to develop in such an iterative way. So we'll see if this works. Yeah, hopefully. Yeah, so pay attention, it says. So this is the expected to be in the first phase of the intervention, where psychoeducation, normalization is in the center. And this is another one. We'll see if this works. Yes. So I hope you find them as nice as we do. So this will be part of a ADHD intervention for adolescents between 13 and 16, and we will do our first feasibility trial this fall. And similarly, we have interviewed adolescents with eating disorders between 16 and 18, and we are now piloting to see if that works as we hope. So I think the way we involve our end users are very important, both when we develop all kinds of interventions, but maybe especially when we develop internet-delivered interventions. So we have used a framework called person-based approach, and they have a wonderful website with a lot of tools, a lot of ways to work systematically with user involvement. At least when we started to work with user involvement, we were not really sure how to balance the 30 years of evidence on treating anxiety, for example, and then with the end user's needs. And we thought we couldn't be dictated by either one. So it's not only the evidence that should speak, and it's not only the end user perspectives that should speak, but we need to integrate those. And of course, also together with the clinician's expertise. So that has been, kind of delicate or difficult balance, but we find that the person-based approach are really helpful in that regard. So that's, the really good resources from the University of Southampton. And then I will continue to talk about how can we then, if we have good evidence, we have good user involvement, the interventions are perceived as effective, not dangerous, and relevant for the end users, how can we scale up these interventions? And that, I think, is the big headache for all of us. So I would like to give a few examples. And one example, which we use in Norway, this is a national platform for children and adolescents. Here you can find information and self-help. That's ung.no. So here you have all kind of information. Here you see there's some information about vaping, the electronic smoking. There is information about eating disorders. And this, in contrast to TikTok or all other information providers, this is edited, and it comes from the public or from the official government. So these are qualitative ensured in the same fashion as Monica presented. So this is what they say now in Norway, that all digital interventions, all prevention, all information for children and adolescents should be at the ung.no platform. And there is a policy that even if we give some information on Instagram or TikTok, the information from the government should not be delivered there, but try to invite the adolescents over to ung.no. So we might have to invite them at their own platforms like TikTok, but then the goal is to get the information and get them into the ung.no and not the opposite, that we provide ung.no information at TikTok. I hope that made sense. So this is the ung.no platform. And this is the platform for adults. This was not that much used before the pandemic, but now it's widely used, helsenorge.no. So here we can find our doctor's appointment. Here we can see some basic elements in our journals, but also, and more so every year, we can also find tools. So this is, for example, grubbel, so rumination, and how can you work on your rumination issues. It is also something about sleep, depression, anxiety. And here the Norwegian government has quite interesting model where they procure, so they buy, they ask the market, both the industry and the health services, if they have good tools or good information they can share, and then they provide this information at helsenorge.no. But I think they're still elaborating on how they can use this and how should the cost be covered, etc. And then I think that for the municipalities, these are very important ways of organizing and providing more general tools that can be delivered online like these ones. Because as we said, there are more than 300 municipalities in Norway. Many of them, I think half, has less than 5,000 inhabitants. So how should they be able, or how can they be have the capacity to do risk assessment, privacy, security assessments? How can they develop or implement tools? It's very hard. And even we live in Bergen, the second biggest city in Norway, even in the municipality of Bergen, to do the risk and privacy assessment it's difficult, and we have experienced that working together with the hospital and the municipality regarding these kind of questions has been very fruitful. So I think that if we are going to use internet-delivered interventions, it's not a viable solution that every municipality are doing their own stuff. So in that regard, also the national platforms and how they can make available evidence-based and user-friendly intervention is a very promising approach. And then I think what, at least I will not speak for anyone than ourselves, but I think we have somehow underestimated the patient pathway. And here I use the word patient, but it's also obviously the inhabitant. But we have made our apps, our digital interventions, and they have more or less been like silos. And it's interesting to see how many of the current programs are developed kind of bottom up. So you have a researcher, you have a health professional who has interest or commitment to a specific user group and maybe even a specific theoretical approach, and then they develop an intervention. And maybe there is then a lack, so then we focus on the app itself or the intervention itself without understanding the patient pathway. And also we are not now currently in the situation that the new interventions are asked for top down. So I think as long as all our interventions are coming from bottom up, we will always have a problem when we need the organization or the country or the municipality to take responsible for this intervention. So I think many of our implementation issues are about where did this intervention come from? Was it ordered by someone, or was it made from my compassion or my commitment to a specific user group? So I think we increasingly, when we are developing new things, we increasingly need to understand the patient pathway. And this is one suggestion, or this is just an example. This could be for example, a young person with psychosis. And then we have the assessment phase. We need to have some psychoeducation. Medication needs to start. We need to work with next of kin. And then maybe working with the more psychological treatment. It can be exposure to certain thing. It can be to manage, for example, sleep problems, and of course, relapse prevention. So when we develop our interventions, at least in the digital format, we need to understand where will our interventions live, or where will they be, and what is the way in and what is the way out. I think we have been, I must admit, I think we have been a little bit ignorant about this. So it's not enough to develop a sleep intervention. We need to understand how and where should this sleep intervention be, and what is the way in and out of this sleep intervention. So I hope that makes some sense. It took a while to realize, I must admit, even if it's quite basic. And then also to understand the needs and the purpose. So if we want, for example, for children or adolescents, if we want to talk to them about cyberbullying or eating disorders or whatever, we also need to understand, so what is the purpose of this? Is this mainly normalization and hope? Then we have to develop certain interventions, but if there is more assessment, monitoring, and treatment, then we have to think differently. So here also, I think we need to be very clear from the very beginning, how should this exist in the ecosystem of our inhabitants, not from our own perspective as a research project in a corner of the hospital. So I would argue that we need a more holistic approach and ecosystem when we develop our interventions, and I guess this holds true also for non-digital interventions. And from the very beginning, understand and involve the people who take the large decisions, the people who are giving sustainable funding, etc., for them to and that we are quite clear about where are we on this. So then we could see that, for example, ung.no or the Kasvun tuki or other could be at one stage, and then other interventions or treatments or rehabilitation programs should be at other stages. So this is a simple figure showing how the information and self-help could be have some purposes, and then the treatments have other goals and purposes, and that could be guided internet interventions, it could be video, it could be blended, meaning that it's both face-to-face and digital. And then we have the rehabilitation. We know that very many of our patients in mental health, they have long-lasting disorders or complaints. For example, with depression, we know that relapsing depression is quite common in our communities. So how can we monitor and give quite rapidly start with relapse prevention or to prevent a new depressive episode, for example? So there's a lot of different ways we could work on monitoring and to make relapse episode as small and short as possible. So there's different ways to think about how we can use technology in these different phases of the intervention. And of course, we could have the circle back up and start the information again. So this was, I was just in Ireland and got some inspiration from Australia that I wanted to share with you. So they, I think, have taken the concept of a more holistic approach, much more, been able to do that much better than we have been doing, at least here in Bergen. And here it's a little bit busy slide, but here you see they have 3 different programs for children and adolescents. And there they see, you can see that you have different kind of context where they can deliver these treatments. So here it was open access, nationwide self-help, so a very good preventive or early detection tool. Then you have the more blended approach with digital and face-to-face treatment, where they can partially face-to-face and partially digital. And then you have also the stepped care ICBT. So we can picture that we're starting with the pure automated self-help in digital treatment program. And then we can step up to more therapist support, more face-to-face, etc. And then we can step down again when we're starting in the more rehabilitation or in the monitoring relapse phase. So this is a little bit more holistic way to set up our digital treatments or interventions. Now, one more thing, what we have realized when we have been trying to implement digital interventions is that we see a need to detangle different elements of the interventions. At least in Norway, it is like the hospital or the municipalities, they buy a digital platform. But the content might be owned by a hospital or a municipality, and it's developed by them, and they don't want to go commercial, so they are owning the digital content. So what we see that there's a need for different business models, so to speak, for the different elements in the interventions. So the one thing is the digital platform, which follows a quite traditional way to buy things in the public service. So you buy a digital platform. But then if we own the evidence-based content, which is often the case, then that needs a different business model. There we don't want to sell our content, but we need funding to maintain and to further develop the content. So we need to have mechanisms in place to be able to do that. Then we would also have the clinical procedures, which is teaching, supervision, etc., which might need another business model or sustainable model. And then, of course, we have the data coming in for these services. So we have both the sensitive health data, where in the Nordic countries we have very strong and clear ways to handle those kind of data. But we also have anonymous user data, how many clicks, how many logons, etc. And they can be very informative when it comes to improving the services we give. So, so this is also a way to make good and sustainable models on how to provide these interventions, especially if these interventions are not packed, so to speak, in an app. So we've been working a lot with this, struggled a lot with it, and please just contact us if you want to discuss this further, because this has been a long way to realize this, and to not at least to get an acceptance for such models, because they're a little bit different than many of the other models we buy and provide things and maintain things in the public health services. So lastly, I'm sorry, this was a little bit small, but how do we get there? Here is a lot of different elements that I think needs to be in place, and we need to understand the different elements in this. Somebody would maybe call it as implementation activities as an umbrella. Sometimes I'm not sure how much the word implementation is helpful for us, because there are so many different things. Something is about culture, something about training, something about technical things. So, but what I have put up here anyway, the leadership is in the top, and that's not, it's a reason for that. Because I think the leadership at all levels in the health services, both at the national and regional and local level, are vital, because when we are developing and providing internet-delivered interventions, we can not go to seminar 1 week and provide the new interventions that I were trained in the next week. So there's a need for technology, privacy, security, all these kind of things. So the need for leadership is even stronger when we are developing digital tools than for other new interventions or innovations in our services. Then we also, just as I said briefly in the slide before, that we need good private-public partnerships. That is also some things that many of us are not very much trained in or experienced with. To our experience, it's really nice when you get long-standing, good private-public partnerships. But then we also need to be very clear about what is owned by you, what is owned by us, and how should we make a good, committing, a long-standing relationship or collaboration in this setting. Then we need sustainable funding, quality assurance, therapist training. I don't know about Finland, but at least in Norway, there is not to be a e-clinician, e-health personnel, e-therapist is not very well established. So we need to work on that. And the user involvement I've been talking about, and the organizational development. Now I got told that my time is up, so that's good. Thank you very much for your attention, and wish you the very best for the rest of the day.
Thank you, Tine Nordgreen. And now we've got a few minutes time for some questions. Do we have any questions from the audience or from the people who are participating through remote access? Not so far, and as I said, you can ask your question in Finnish if you wish, and I'll translate that. Tine, just briefly go back to your point about we need more holistic approach in terms of creating this kind of robust ecosystem for intervention. From the point of view of Nordic collaboration, how much room for improvement can you see there, that we could kind of learn from each other and kind of implement similar kind of systems in this holistic approach?
Yeah, I think that is a very, very good question. And we have, as you suggest, a lot of improvement there's room for a lot of improvement. And we were having a meeting earlier this spring with Finnish, Swedish, Danish, and Norwegian people. Petra and her colleagues were there. So I think this was just the very start. And even when we go to the Netherlands, we see that how they organize their health system is quite different from us. So I think the Nordic countries has a lot in common, and we should use that potential to a much larger degree. So I support what you are suggesting.
Fantastic. Going back to the animation as a form of intervention, that was fascinating. You were saying that you're piloting that method, if you like, later on this year. Can you elaborate on that a bit more?
Yeah, so for ADHD, of course, the medical treatment is primarily, so we will not do that. But what we see, at least in Norway, that a lot of adolescents receive the diagnosis, they maybe receive some medication, and that's it. So we are lacking the psychosocial elements of the ADHD. So then we will make quite easy animated intervention, where first of all, there's a lot of, as I said, normalization. This is how it is, and I can recognize myself in these animations in this text. And then the adolescents expressed a quite clear need for talking about emotional regulation and social interaction. So not that much about attention, concentration, these typical core ADHD symptoms, but they wanted more an intervention targeting especially the ups and downs and the complexity of the social interaction. So we'll see how it works. We don't know yet.
Fantastic. Well, good luck with that, and wish you all the best. And thank you very much for joining us. And I'm really sorry about the flight, Finnair. Hopefully next time you'll be here in person. But it was lovely to have you with us through this. Oh yes, one more. Yes, please do. Just one more question from the audience before we go. There's always room for questions. We'll just get the mic.
Yes, my name is Maria. I would like to ask you about how do you take the children or patients? How do you interact with them when you are developing these methods? You said that the user experience or feedback from the users is very crucial. Do you have panels or children, or just you work with individual children, or what is the system in your feedback process?
Yeah, thank you for a good question. So what we have, so just recently, I can share it in the chat, so we have just recently interviewed 16 adolescents with eating disorders and 16 adolescents with ADHD, and the eating disorder publication is already out there, and the ADHD is on its way under review. So what we do is we interview them individually, and then we get the feedback. What's important for you? Have you an experience? How was the treatment, face-to-face treatment? And then we work on that. Then we draft easy or quick drafts of the intervention. Then we show it to them, still individually, and then we elaborate or continue to work with our intervention, and then we show it to them again, and now we're going into the trial. So, but I would really recommend a person-based approach. They have, they also, a lot of practical tools, and it's really helpful. Everything we do, we have learned from the British people working on that.
Great, thank you. One question from Petra.
Yes, thank you, Tine. I was wondering about the quality control you mentioned. You are involving the research partnership here. So is it always involving a research collaboration? And I'm curious to know, because you said that there will be coming up a lot of new digital interventions in the coming years. So what do you have to say about this?
Yeah, that's a really good question. And we are still in our early stages, so we haven't, all the routines and practicalities is not sorted out. But what we recently recently made a routine for, and that was accepted by the health authorities, is that we will do a more clinical qualitative assessment of the interventions annually. So this means that the people the owners of the program will annually receive 100,000 krona from the end users, or not from the each individual, but the health services that uses this intervention, and then they will get funding to look at user data, look at the more satisfaction data, etc. So that will not be research; that will be more clinical quality assurance. When it comes to the researchers, they will mainly be involved with the ongoing studies, which is, ethical approval, everything. So we are trying to separate those two processes, and especially we have not been able to do the more clinical qualitative assurances or the updates. So that has been important for us, but it has been a long way to get acceptance for that, because the focus has been on the technology and not the content on the technology. So I think we should divide it as you maybe suggest.
Great, thank you. Unfortunately, our time is up, but really grateful to have you with us, and all the best with your important work there. Thank you very much, Tine. Let's give a round of applause.
Thank you, guys.
Right, time flies, and our last speaker of this morning comes from the beautiful city of York, University of York. It's an honor to have Professor Martin Weber with us here today. He will shed light on how to improve the quality of social work practice. And again, at the end of Martin's speech, you can ask questions from him in Finnish or either English. But please, without further ado, please welcome on stage Professor Martin Weber. Sorry. Oh, no. Sorry. No. I think the plan was that you'll join us. Can we have the mic? Are you okay to talk with the just normal mic? Yeah. Can we have one mic here on Martin? There was just a misunderstanding in terms of miking you up. No worries. This is always the case with technology. As we just see. Sorry? Oh, yeah, sorry, I thought we were going straight on. We're having a break now? I apologize. In that case, forget everything. Let's go on a break. Thank you very much. See you in a bit. Okie dokie. As planned, we have enjoyed our break, and now start to continue with the program. Can I ask you, dear friends, take your seat, please, and then we can continue networking and chatting on our lunch break. But before that, we have one more speaker, as you probably know by now. Right, without further ado, please welcome on stage Professor Martin Weber from University of York.
Thank you very much. I'm grateful that you've had a break. I wouldn't want you to sit cross-legged for the next half an hour. But I will not keep you from a prompt lunch break. First of all, thank you for inviting me to Helsinki to a birthday party, a celebration. Very grateful to come, very grateful for the invitation, and to be amongst friends thinking about implementation. And that's really what I want to reflect with you today around implementation research. And starting from a background in social work, I'm a social worker by background. I undertake primary research with colleagues at the University of York. I have a research team who are engaged with a whole range of studies, through from ethnography through to feasibility trials and larger randomized trials. We do evidence synthesis. And some of my earlier work has been put into practice, and I want to reflect a little on some of that with you today in terms of what implementation looks like, what the challenges are, and how that might be more difficult in crossing boundaries. And I also want to draw on two other pieces of work which are not my own, so please don't ask me too many questions about them, but are particularly thinking about from Nordic countries, or specifically from Finland and the UK, in terms of crossing boundaries with implementation of interventions. And I'm primarily working around social interventions and complex social interventions, and we'll reflect on some of the difficulties with that. But first of all, an anniversary celebration, a jubilee, is about looking backwards, looking forwards. So I thought I would start with a reflection on where are we in terms of using evidence in social work. And please excuse this narrow disciplinary focus on social work. I understand it's a broader audience here today, but we are quite a way behind psychology, medicine, other professions in generating evidence and using it in practice. So I started with just looking at the web of science and seeing how frequently evidence is mentioned at the same time as social work. And you can see this massive growth in citations over the last 20 years. To be fair, if you were to put social work into Web of Science with nothing else, you would see this massive growth in citations. It's a growing discipline. It's a new and emerging discipline. But what you can see here, I think, are two things. First of all, this growth in the use of evidence, or at least the word is featuring in citations and abstracts. But you can see here 2014 as well, and you can see the change in trajectory of that line in 2014. So, what happened in 2014? Then I looked at evidence-based or evidence-informed, two ways of looking at the use of evidence in practice with social work. You can see this same trend, but our number of citations has gone down quite radically. But there's still this upward trend which has leveled off in the last couple of years. Looking at implementation, evidence and implementation, we've got a bit of a shallower growth, but again, we're only looking at a maximum of about 250 citations a year, which is still really very modest. And then the final one I looked at was randomized controlled trial and social work. And this is really the nub of the problem, is the very, very small number that we're talking about here. So it was for the best part of the first decade in my 20-year period, you can see a line which bumbled along virtually close to zero, certainly between 0 and 20. And it has risen a little bit since then. But the big message is studies of social work, social interventions. I'm not really talking about psychosocial interventions here, but much more of the more complex social interventions that social workers are involved with. We don't have that very high level of evidence. We talked about earlier in terms of that top really good evidence. We're still struggling to see that in social work as a whole. So in summary, there's an increasing interest in evidence and using it to inform practice. Similarly with implementation, but trials are still rare. What is being implemented, and can implementation science help at all? I want to address that question and reflect on it using 3 examples. Thinking about this notion of implementation science, which in social work as a discipline, we are just beginning to come to terms with it, just beginning to understand it, just beginning, I think, to see how it can improve what we do and how we implement interventions. And I think these 3 bottom bullet points are important here in understanding how this best can help us in putting interventions into practice. First of all, understanding it as a dynamic social process that is shaped by the context. And it's shaped by the context in which the innovation has come from and in which it is taking place. More importantly, by the people involved. It's a point I'll come back to. It requires the involvement of stakeholders at all levels of the organization, not just those implementing, but those supporting, those leading, those developing the strategy for that organization. And thirdly, it's a change process. Change processes are inevitably complex. They involve people at different levels of the organization, but also at different levels of understanding and different levels of training in order to improve practice and improve outcomes for the people that we're working with. So the first example I want to draw upon is from my own work. It's an intervention we called Connecting People, where the aim is to support people to develop their social connections. The intervention model was developed from services working with young people with psychosis, early intervention services for people with psychosis in the UK. We conducted an ethnography to understand how social care, social workers were supporting people to develop their social networks. At a crucial time in that first episode of psychosis, people tend to drop out from school, education, training, or employment. And it's really important to provide opportunities for people to develop their networks if they're not able to return to those settings. We undertook a quasi-experimental study, so here's an example of where a trial hasn't yet been conducted, but we got some quasi-experimental evidence, which found improvements in access to social capital, the resourcefulness of people's networks when the model was used in full, when there was high fidelity to the model. The model itself focuses on co-production between the worker and the person they're working with in identifying new activities, overcoming barriers to engaging with those activities. And the barriers are acknowledged both for the worker and for the person that they're working with. The role of the team or the agency is also acknowledged at the very beginning, at the outset. So it's a systemic model within an agency, not just an individual practicing, but an agency supporting and hosting that practice as well. And the embeddedness of the team within its community is vital to making this work. But it's flexible and adaptable according to context, which makes it translatable, which we think is really important. But coming back to the point of complexity, the theory of change, or the model which describes how the intervention should work, is inherently complex. These are, in fact, the findings of that ethnography modelled together to put into one intervention model. And I don't have time to explore it in full today, but just to say the aim of the intervention is to get these circles spinning, is to get the process moving so that outcomes could occur. We have outcomes over here on the right-hand side, enhanced social network for the person who is the subject of the intervention, and also for the worker in green, their knowledge of the local community and its networks also improve in order for them to work together in co-production with the individual. So this complexity had to be simplified in order for people to understand it, make sense of it, and put it into practice. So we developed alongside this practice guidance, which took a step-by-step approach. First of all, you assess whether or not it's relevant for the person that you're working with. You're mapping their existing connections. You're better understanding your own connections as a worker. You're making a plan. You're stepping out and putting that plan into action. With support, you're supporting the person where they need it, or finding support for them where it's appropriate for them. You're taking a step back and reviewing how it's going. You're taking stock. And within the process, you are explicitly acknowledging barriers. So in that the circles of that diagram of the theory of change, there are two circles working against the motion of the main circles, which is saying there are barriers. You need to overcome problems which are acknowledged in the intervention cycle and you've got to address. Also, there are two macro perspectives, one around the organizational culture and one around reviewing the whole process. So undertaking some outcome measurement to see if it's worthwhile doing. Is it actually working? So with these processes, we undertook an implementation study to see if we could deliver this in a context where it is much more challenging to deliver in the National Health Service in England, where there are predominantly biomedical models of treatment. Social interventions are not necessarily supported, they're not favoured, but there are workers who are keen and interested enough to be able to put these into place. So we developed intervention materials, implementation manual, training manual, practice guide, service user, leaflets. We delivered these to 5 teams in mental health trusts and 5 mental health trusts. And we conducted a quasi-experimental study where we had control teams who didn't have access to these materials. And this study taught us a lot about what not to do in implementation research. So I find it valuable to reflect on because I've learned a lot from this. You cannot just provide materials, provide people with some funding for training, and let them get on with it. You've got to be much more actively involved and engaged in the process. So The implementation team in each trust, there was a control team and an implementation team, they decided how best to implement the model. That was their task. And overall, we studied over 150 people over a 6-month period using structured outcome measures. And we also talked to practitioners at baseline and follow-up in focus groups, and we had some qualitative questions. So there's a qualitative process evaluation embedded, which was valuable because it told us what was happening. What we also wanted to find out was whether or not the context affected the outcome. So we looked at the implementation climate within the team. And we used a scale which measured whether practitioners or the team were ready to implement the intervention. And we actually found that those in the control teams were in a higher state of readiness to implement the intervention than those in the intervention team. So it wasn't a cluster randomized trial. We didn't randomly allocate them to intervention or control teams. It was a decision made locally within the NHS Trust, pragmatically made, and the managers had selected teams where the practice was weakest, where the practice was poorest, where they wanted improvements to be made. So we had the opposite effect. We were starting with the teams where work was most difficult, where turnover was highest, and where the practitioners were perhaps least willing to implement something new. So we learned a lot through that process. Don't do that again. A randomized approach would have minimized that variation. So we weren't able to do that. We were able to have a very good follow-up rate for outcomes, but we found no differences between the two groups. There was a non-statistically significant trend towards improving outcomes and lowering cost in favor of the intervention, but it was all about how could this be implemented more fully. Looking at the fidelity measure, we found that it was not implemented, and it was not implemented in full. The fidelity scores, in fact, were similar between the implementation and the control groups. So it didn't work. Something went wrong. And there were a number of reasons for this. First of all, there's the pressure of work at the time. This was conducted pre-pandemic, but it was still a high pressurized environment in terms of work. And the practitioners felt it was another thing to do on top of their busy workloads. So they didn't necessarily look at the materials, the training wasn't necessarily provided, and supervision was not kind of universal. We had some pockets of good practice where it was used, training was organized, was delivered, and where teams were supported with the implementation efforts. But also the broader context of the practitioners focusing on mental health crisis rather than longer-term work was a big problem. They had very little time, they were under pressure in their own workloads, but the teams were under pressure because of turnover, understaffed, and no time to immerse themselves in something new or taking themselves beyond their usual set of activities in terms of understanding the communities of the people that they were working with. There was also a lack of organizational buy-in, which is kind of ironic because the 5 sites we went to were very keen for us to support them with this process, and there were workers within them who were very keen. But it needed a bigger macro buy-in from the organization. A systemic whole structure needed to say, yes, this is what we're going to do. We're going to invest time, money, resource into doing this. So taking from this was some really important learning about it's not just training people, it's about that whole system needs to be behind the implementation effort. And also there were some perverse incentives at operation as well. People, in some sense, had an incentive to stay in the unwell position because of access to benefits and to services and access to treatment, which there was a cliff edge, that when the treatment finished, they had no support at all. There wasn't anything in terms of voluntary sector support. So people didn't necessarily themselves want to move into a recovery position because it meant that the services that they relied on were more likely to be withdrawn at some point. So the people we were working with there were either too unwell, they were in the midst of a crisis where this work doesn't necessarily work, or they were edging towards discharge from the service completely. So we did find from this process, though, what is likely to help implementation, and it's very much around leadership. It's about the people that are involved, not just the workers implementing, but supervisors, managers, and the whole system. It's about making it possible within a very pressurized system. So ongoing training, supervision, consultancy, manageable caseloads, availability of the community resources, and up-to-date knowledge and engagement with them, and a leadership around the process, and not discharging people too quickly. So what we took from this, we brought into a project that we undertook with the Jewish Family Services in New Jersey in USA. And this is the first example of international portability of connecting people that we undertook. And I've got two contrasting photographs to kind of make the point that York is very different from Atlantic City, from Harry Potter land to Las Vegas almost. Very, very different contexts. But what we found was that implementation worked very well. Now, culturally, there are similarities. But in terms of the way in which services are organized in Atlantic City and the way in which the government is involved or not involved in the provision of social services, it was quite different. But what we did was we worked with the team there to provide an adaptation to the implementation materials, so they were using local examples, local languages. It was still English, but we had to change some of the spellings into American English rather than UK English. And we piloted it with people who had really very, very complex needs. The organization was basically saying, look, if we can get it to work with the group who are the most difficult to work with, using their terminology, people who have overlapping mental health needs, criminal justice needs, and housing needs, then we can get it to work anywhere within the organization. So we conducted a pilot. It was a trial interrupted by COVID, so our data collection wasn't as great as we had wanted it to be, and we didn't find differences in outcomes because of the small sample size. But things were going in the right direction. And what we could see was that the workers were able to embed it in their practice because the agency supported them to do it, and because it was what the agency wanted to happen. And we, last month, did some train-the-trainer training for other service managers so it could be spread across the organization. And that leadership really, really helped. There was still a high turnover of workers. There was still a big pressure in terms of work, but they were supported and expected to implement it, so they were able to do it. There was also a strong fit with the organization's mission, the vision, the ethos. So the values of the intervention model fitted well with the organization as well, and that certainly helped. Much more so than in the NHS in England. The agency and the worker limitations were acknowledged, and the barriers to implementation were addressed at source. So in the training, we talked about, well, what are some of the problems that you're going to encounter, and they were upfront, and they were addressing them straight away from the beginning. As always, there's more to do. We did fidelity measurement, and found that there is still a gap between full implementation. And they can do more, they're aware of that, and they've got a program ahead of them to put that into practice. The second example is one where we have taken from Finland, from Western Lapland, the model of open dialogue, and are trialing it in the UK. So from snowy Lapland to wet London is the example here. You probably have a greater familiarity of this than I do, but for those who don't, Open Dialogue is a model for mental health services, working primarily with an individual's family and their network during a crisis, and it is used to support people at home rather than provide institutional care, drawing on a variety of systemic family models. And it's based around a treatment meeting with that network, with the family, very soon in the referral process. Focuses on the relationships, the ecosystem, rather than individual pathology. As I inferred with the services in the UK, our models are very much based on individual pathology. They're very much focused on a medication-led approach. So this is somewhat of a cultural shift for our services to think about open dialogue communication involving the wider family system at the beginning of a period of crisis. And the model which has been tested so far is something around peer-supported open dialogue, where people with lived experience of mental health problems have been trained to act as workers, to work within teams, employed within services to undertake dialogue, open dialogue. And they convened the social network meetings as the focus for the intervention. And this was alongside other health and social care interventions that are available to them. So medication was still available, hospital admission was available if it was needed. This was tested in a small pre-post study, and it's now being scaled up in a larger trial. And the Odyssey trial, we're waiting for it to be published. We don't know the findings, but it's a large multi-center trial of open dialogue. So the implementation here hasn't really been in routine practice. The implementation has been for a research trial to be undertaken across a number of sites. And the key differences were, it hasn't become the model, the main method. It has been integrated into existing services, which is the limitation. There are significant cultural differences between the two contexts. And there's been variation in implementation where open dialogue has been used in many different countries. Scoping reviews and systematic reviews have all found that it's difficult to make comparisons because what has been implemented is quite different, which raises this question of adherence and fidelity. But fidelity to what? And that comes into my final example, where the Hackney model of children and family services, again, there'll be colleagues in this room who will be much more familiar with this than I have, has been transported from the UK to Finland. Here's Hackney, here's Helsinki. They look quite similar. They're not, but the pictures look quite similar. Helsinki's much nicer than Hackney. Oh. What happened here was reclaiming social work was adapted for the Finnish context, and the systemic practice model adapted, and quite explicitly adapted a model that was developed in Hackney in East London for rolling out across Finland. There were some key differences. The training programs were different. Changes were made at the team level rather than system level. Teams were larger, caseloads were higher. But many of the key elements on the left were still put in place as far as possible in Finland. And some of these similar challenges emerged. High variability across the sites and the teams, a lack of leadership, a lack of resource, variation of implementation of the core components. The systemic techniques were not necessarily fully implemented, variation in team structure, and so on. So some of these similar messages are emerging from all of these studies, and all of these examples are saying, this is difficult work. It's hard to get right. It's hard to ensure positive outcomes from some of this work. Looking from a UK perspective, I would argue there was limited evidence of the effectiveness of reclaiming social work. So there were no trials that were conducted. And it was really implemented in the UK because of a political vision, because of strong leadership, and effectively one person who's kind of driven it through. And also in terms of looking at the systemic practice model, evaluations in Finland have found similar things in terms of a limited difference in outcomes between intervention and control. Variability of implementation was a consistent issue, but we could also ask questions, does it really matter? If things are as good as in the control group, or if the control group is as good as the implementation group, if the outcomes are the same, is that okay? That's perhaps a controversial question to ask in a hall of people concerned with implementation. But what is it that we are really looking for when we are undertaking implementation studies in terms of whether or not something is improving practice or not? It comes back to the question, though, in terms of adherence to what? If you're adapting a program, are you looking at fidelity to the adapted program, which may be less effective or maybe more effective than where it came from? Or are you looking for fidelity to the original model, the original program? So, my last minute before I finish, some concluding thoughts. First of all, there is limited high-quality evidence of effectiveness of complex social interventions. Implementation largely happens anyway in practice, in the absence of this. So earlier on, we had seen how many interventions have no or low levels of evidence around them. As practitioners, we utilize models irrespective of the amount of evidence that is there. Can't underestimate enough, or overestimate enough, sorry, that practitioners, service managers, researchers need to collaborate throughout the whole of this process. You cannot ask a researcher to come in at the end of the process and evaluate it post hoc. We need to be involved as partners throughout to see how we can improve the processes and evaluate outcomes from the beginning. The translation from one context to another is complex, inherently difficult, fraught with difficulties, but offering opportunities for new visions, new ideas, new ways of thinking, and improving the quality of practice. I think that implementation science can help us a little bit with this, but we could also help implementation science. We can say, we are dealing with some complexity of lived reality of people, and we can feed into the field of implementation science some insights into that. And I believe that you are in the process of doing that, really. And you are the people with the strong vision and the leadership skills. So, in summary, congratulations on your achievements so far. Here's to the next 10, 20, 30 years and beyond. This work is not easy, and I think you are the right people to do it, and are probably responsible for some of that uptick in the evidence base that I referred to at the beginning. So, thank you very much.
Thank you, Martin. Thank you for that thought-provoking presentation. And now we've got some time for the tricky questions that you didn't want to receive. Any questions from the audience or from our participants on the other end on the line? I, for one, had never heard of that Hackney-Helsinki comparison or the model exchange. Can you were kind of going through that kind of the tricky and the difficulties of kind of changing the same model between two different cultures and societies and the structures and everything. Can you elaborate on the how can you overcome those hurdles, say, if we talk about Helsinki and Hackney, the vast social differences that they have?
I think it's about breaking it down. So it's about looking at the individual components that you're trying to put into place and understand which in the original model are the most important ones or the ones which are likely to lead to change. So, for example, in the Hackney model of reclaiming social work, you had a consultant social worker and you had a small group of practitioners focused on one area of work with smaller caseloads. Now, that itself, without any of the interventions they were using, could be the thing which is effective in producing change because they're not burnt out, they've got more time, they've got to focus on the work. It could be that element. So if that one element was taken, and there is research evidence from Finland outside of this, which says that if you were to reduce caseload size, make teams more manageable, you can reduce burnout, you can improve outcomes for people, then that might be the active ingredient, the element of the intervention package, which is the one that makes a difference. Or it could be that they're using high-fidelity motivational interviewing, for example, as an intervention technique in their work with children and families. It could be that element which is the effective one. That's where the evidence base lies, lots of trials around that. So what I'm trying to say is, I think understanding the elements of the intervention, what is needed, what could be changed, and breaking it down in that way, in other words, having that research a priori, that will help that implementation effort so that you can then put into practice some elements of it and not others, and not worry too much about it because you've done the important elements of it, as it were.
And kind of less is more.
It could be.
Yeah, that's really interesting. We've got one question from the audience. Fantastic.
Yes, Elina Aaltio from the University of Helsinki. So thank you for presenting some of our work from me and my colleague Nanne Isakorti. So we have evaluated the implementation, and also we try to evaluate the outcomes of this Finnish version of Hackney model. And just to comment, you asked if it makes, well, you didn't ask, but maybe a critical comment, if it makes sense to build a program theory for a model like after the model has already been implemented. So I think one of the problems within social work development projects is that they quite often produce something they call a model or intervention, but they actually don't present a logic model or a program theory. And that was the case. Like, there was a description and a lot of PowerPoint slides introducing what's the Finnish model for systemic practice looks like, but there was no program theory. So I think we as researchers made like groundbreaking contribution in the field of Finnish social work research, because this was, I think, as far as I'm aware, like the first formulated program theory for a social work intervention in Finland. So I think it was really important within implementation research area to show that this is something you should do, and this is something you can do already afterwards, because as we know, this model is still being disseminated, even though we know there is no evidence of its effectiveness, but it's being continuously, it's in use and it's being disseminated. So I think it's important that there's at least one like written description that is based on analytical research project that we try to formulate a well-written program theory for this model. And the other question is about, does it make sense to assess fidelity if there is no pre-written program theory? So that's a good question, but it's also, I think it's important just to try and to show that this is something you should do and this is something you can do, although it's not a perfect fidelity assessment. At least it's one of the first endeavors to do something like that within social work. So I think it's like, as we know, there's a lot of work to do, but you just have to start somewhere.
Thank you. And yes, I completely agree with what you're saying. First of all, program theory is essential, and it's a massive contribution to understand this so-called black box of the intervention. So what's going on? What are the processes and mechanisms? That's an important aspect of this work, is unpicking some of those elements. And it's through that process you can develop the fidelity measurements. So I would argue that it's better to do that with a Finnish model than with a UK model if we're looking in that direction, to make sure that the fidelity is in relation to your program theory, because it's going to relate to what is happening on the ground. And coming back to the point about outcomes, I haven't found, or have found very, very few, interventions where you can show a difference in a trial. It's very, very difficult in social interventions to, when you're introducing something new, which is complex, involves a number of different components, to find a difference in outcomes. Much more easier with a discrete intervention, and I say motivational interviewing as an example because it's part of the model. There are particular aspects to that approach which you can assess fidelity, you can put into practice very, very, shall I say, easily, whereas a whole system change and a whole structure of a practice system is much more difficult, firstly to change, but also to implement in a way that's faithful to a model, and therefore to evaluate the change. So what I'm trying to say is, I'm not too worried about a lack of kind of efficacy following implementation. I would be worried if the results were a lot worse in the implementation group than the control group. But if they are similar, I think that should then lead us into thinking about, well, how can we use that as our baseline to make improvements in the future? I'm also not denigrating evaluation, because that's what I'm in the job to do, is to produce outcome evaluations. Because it is important to know exactly what is going on, but to use that as a way for learning, rather than to say it's no better and therefore we're going to stop what we're doing. I would say, well, how can we make it better, rather than going back and starting again. Does that help?
Strong nod, definitely.
Okay.
Thank you very much, Martin. But unfortunately, that's what we have time for the time being. Thank you very much for the fascinating presentation.
Thank you very much.
Let's give a round of applause to Martin.
Thank you. Thank you.
And also to all our 4 fantastic speakers this morning, let's give a warm round of applause. Thank you for taking the time and effort to come here to be with us. It was our pleasure. Right, that's it for this morning seminar. Hopefully it was useful, thought-provoking, and gave you a lot of ideas for the future. And now we're going to break for lunch and then continue chatting and networking and celebrating, of course, this Jubilee seminar. And we'll be back here at 1 o'clock. So enjoy your break. Thank you, and see you in a bit. Thank you. Bye.